Hi, welcome back. Today we are going to see a NCLEX trap. So we are going to see here why the student is going to pick the wrong drug. I'm going to discuss the topic about VT, that is ventricular tachycardia versus SVT, supraventricular tachycardia. And here, mind you, the one is very deadly. So let's dive into the topic. The ventricular tachycardia, we have to always see the ECG. The ECG, we are going to see the QRS complex, and the QRS complex should be 0.12 seconds. If it is prolonging more than 0.12 seconds, then we should doubt it is wide QRS complex. And the rhythm might be regular in ventricular tachycardia, and rate usually falls between 150 to 250 beats per minute. So the golden rule how to find the ventricular tachycardia is it's a wide complex tachycardia where the QRS complex is above 0.12 seconds. So this is the gold standard until it is proven. So here is the ECG which shows the ventricular tachycardia. Here I am going to tell you the normal EKG which is in the first strip, and the second strip shows the ventricular tachycardia. So in usual ECG, we have enough time for the QRS complex that it is, and what happens during this QRS complex is we have enough time for the blood to get filled in the ventricles, right? So this is the normal ECG with the diagram illustrating. So what happens in ventricular tachycardia, as the rate is very high and it is monomorphic type of ventricular tachycardia where it is more than 100 beats per minute. So the QRS complex is very narrow, and the time for the heart to contract is very less because as it is the heart rate is very high, and the blood gets not adequately filled in the ventricle chambers. So we will not get enough blood for the cardiac output. This is how the physiology goes behind the ventricular tachycardia. So what is the exact management we are going to do in this ventricular tachycardia is there are three different types. That is, if VT, ventricular tachycardia with a stable pulse, patient is stable, so here we are going to manage the patient with amiodarone or lidocaine, that is antiarrhythmic drug. And if the VT is with pulse and if the patient is unstable, then we might go into synchronized cardioversion after taking consent and giving a mild sedation. This is a proper procedure which has to be done if the drug is failed, and it can be done if the patient is unstable. And next type of ventricular tachycardia is the pulseless ventricular tachycardia, where we can see the defibrillation at the priority, and we can do along with CPR, and we should also go for epicardial pacing in this case. So the NCLEX trap here is we do not give adenosine thinking it is an SVT. If you are doing so, the patient can rapidly deteriorate because there is no time. The VT might go and get converted into VF. It is another lethal arrhythmia of the cardiac conditions, right? So I'm going to tell you about the supraventricular tachycardia, what exactly it is. Here the ECG is very narrow, so it is less than 0.12 seconds, and the rhythm might be regular, but the heart rate is again here is 150 to 250 beats per minute. But the P wave is always often hidden in the QRS complex itself. So what is the clue? How we are going to find this is we are going to see a narrow QRS complex which is very fast, and this is called the SVT. So I am going to show you an ECG where it depicts the SVT. Here we can see the QRS complex which is rapid, and it is very narrow. It is less than 0.12 seconds. And how it has been managed is we are going to give carotid sinus massage, Valsalva maneuver, and an injection adenosine is a choice of drug, because this is happening because the supraventricular tachycardia, where the impulses is being generated from above the ventricles, this forms a necessary pathway and it irritates the ventricle and we have the SVT. So these things can be managed by all the management which I just said now. So what exactly is the action we need to perform during this SVT is, if the SVT is stable, then we have to go for vagal maneuver. That is what we are doing, a carotid massage, a Valsalva maneuver. All these things can be tried. And if it is not settled by all these, then we can go for injection adenosine. It has to be given very fast by rapid push following by a bolus saline. And it has to happen everything within few seconds. And if the SVT is unstable, then we should go for synchronized cardioversion. In spite of medication and Valsalva maneuver and vagal maneuver, it is not getting treated, then we should go for synchronized cardioversion. So the NCLEX trap here is, we do not defibrillate any SVT patients, right? Because we can treat it by cardioversion, and injection adenosine is the first line of drug. So here next we can see the difference between the VT and SVT in just one line. One detail can change everything. Here the features in VT, it is the QRS width is very wide, and in SVT it is narrow, and the origin in VT, it always origins from the ventricle of the heart, and SVT, it is originates from the above, that is from the atrium. It forms an auxiliary pathway. And adenosine is not given in case of VT, and SVT we should give adenosine. It is a treatment of choice. Next, danger level, VT is very lethal. If you are not treating the patient within time, within seconds, the patient might collapse and you may lose the patient. Next one, in SVT, it is not too dangerous, but it should also be treated. Next, priority, we should always check pulse in case of ventricular tachycardia. In case of SVT, we should always control the rate of the patient because the ventricles is beating really very fast. So the classic NCLEX type trap question is here, where the ECG shows heart rate of 190, regular rhythm, wide QRS and patient is alert. What is the basic action? So if it is heart rate is higher and the patient is stable and the QRS is wide, the answer is amiodarone. We will never give adenosine because the QRS is wide, it is stating in the question, and amiodarone is an antiarrhythmic drug. Since the patient is stable, we can treat it by medications. Adenosine in case of SVT, it is not, adenosine is given in only in case of SVT. So the NCLEX memory line is, if the QRS is wide, it is VT and it is deadly, so shock the patient, or we should treat with amiodarone. If the QRS is narrow, it is SVT, so we should try vagal maneuvers and injection adenosine is the choice. So this is the way we need to crack this type of question. Okay. This content has given you some knowledge regarding VT and SVT. Do comment and subscribe for more content. Thank you. Happy learning.